Hi everyone. These are some extra cases from the T1 and T2 mapping talk. Um, First of all, here's a 74-year-old male with fatigue, dyspnea, and low voltages on ECG, as well as an echo with diastolic dysfunction. On these magnitude images, you can see that the patient has a moderate-sized pericardial effusion and bilateral pleural effusions, right larger than left. The late gadolinium enhancement images are degraded by respiratory motion artifact. Clearly, the patient had difficulty breath holding, but essentially, there's not much to find. This is a bit of a foreshortened LV apex. They've caught more of the right ventricle apex than the left ventricle apex, but allowing for these kind of issues, there's nothing to find in the magnitude images. Now, if we go to the T1 maps, we can see that there's diffuse abnormality across the bullseye plot from base to apex, with T1 values of 1100 to 1240, and our upper limits are only 1071, so grossly abnormal diffusely throughout the left ventricle. On our ECV maps, you can see that again the bullseye is extremely abnormal with ECVs ranging from 38 to up to 52, and our normals would be up to 28 only. So this is clearly cardiac amyloidosis, despite the essentially normal magnitude images. Um, and so this paper then comes into effect with an ECV of greater than 45. These findings are independent adverse prognostic indicator in cardiac amyloidosis. And so using tissue maps, we are able to confidently diagnose cardiac amyloidosis in this case. Here's a 39-year-old patient, anabolic steroid user who's developed anabolic steroid-induced LVH, which is mildly asymmetric with a 14 millimeter interventricular septum at end diastole and associated low normal T1 values. You can see that throughout the LV, the T1 values are less than 970. Our lower limits are 942 at our site on our 1.5T scanners. ECV is normal, late GAD is normal, and so this is related to steroid-induced LVH. Um, we were asked to evaluate this right atrial mass, 63-year-old female, and tries we might we only got low signal back from the mass, and this is just a reminder to say that on standard CMR sequences as well as tissue mapping, you will struggle to characterize anything that is fully calcified. Here's a non-gated CT we pulled up while we were at the scanner trying to do the cardiac MRI, and we subsequently did a cardiac CT as well, which basically showed that this mass was fully calcified. Here's another patient with risk factors for amyloid who had an equivocal pyrophosphate scan. And on MRI, we can see on tissue mapping, we've got essentially normal T1 values and an average, a global T1 of 1017 milliseconds, but an ECV that is abnormal at 33%. And so there is literature out there to say that sometimes ECV is more sensitive and it's able to detect early cardiac amyloidosis before the T1 values become abnormal, and this is one such suspected case. Um, so in terms of the ECV maps, we can see in this case with a very obvious late gadolinium enhancement due to pericarditis that the ECV is also abnormal for the pericardium. Lastly, this is a case just to show you that just like the ones that we talked about during the talk, where there is a septal kind of wobble in diastole because of maybe bundle branch block, you can get essentially a contamination of the T1 values in the interventricular septum because when the sequence is expecting the interventricular septum or the myocardium as a whole to be fairly quiescent during diastole, you're getting this extra wobble. In this case, it's because of an atrial kick. You can see the wobble in diastole because the left atrium is ejecting blood into the left ventricle, causing it to wobble. And so the elevation in T1 values is not actually real, but if you track the raw images, on this 1.5T Phillips scan, you will get essentially normal values from the ROIs that are tracking with the moving interventricular septum. And I hope these cases were useful. Thank you for your attention.